Good afternoon, everyone, and thank you so much for the opportunity to speak here this afternoon about my favorite subject. Stephen, thank you so much for that overview of the integrated models on a global level. I'm going to be speaking more about specifics around children, but earlier this year, Stephen and I were in Geneva for a side event at the World Health Assembly. And you walk a lot in Geneva, I'm sure you know. And one day, quite early in the day, Stephen looked at his wrist and said, "You know, I've already walked 10,000 steps." And I think my response was, well, if you walked 10, I must have walked 20,000 steps. And to me, it was really an example of what's happening in palliative care. As palliative care for children, we started way behind the more adult-focused palliative care, and we're still rather running to catch up. But really what I'm delighted to see in different countries, and especially in developing countries, is that there are models that have really and truly have got it right. They've grown up very quickly, and I'd like to share those with you today. So I'm going to speak a little bit about the context, and Stephen has given you the major context about the different models, and they all have a lot of elements that are the same. Some examples in developing countries of really successful integrated models. And look at what made them successful. Why are these working when others are not? And of course, just a little bit on the challenges to this. Now, Steve showed you the general development. This is the mapping that we do at ICPCN, looking at the development of palliative care for children. And while it looks pretty bad, when we started in 2012, it looked far worse than it is. But you can see that where the greatest need is, where there's so little is happening, is in the developing world. So we decided we needed to know how many children are out there who need palliative care, and went to UNICEF, and they were great. They said, right, let's have a look and look at 3 countries and develop a methodology for identifying the prevalence of these children. And so we looked at 3 countries, and then we took the methodology and we expanded it to another 23 that amongst them held 60% of the world's children. And we took these countries with really large populations like India and China and Indonesia and countries in Africa. And what we came out with was a generalized palliative care need of 21 million, but a specialized need of 8 million. And the average prevalence was 43, but that really told us nothing, because it went from 20 in 10,000 in countries like the United Kingdom to 119 in 10,000 in countries like Zimbabwe. And what we found is that where there was a high HIV prevalence, the need for children's palliative care was particularly high. And when we as ICPCN are doing our assessments, we estimate that really less than 1% of the children who need palliative care are receiving it. And most of these children are in the developing world in sub-Saharan Africa and Southeast Asia. And we know the challenges that people experience living in these areas. Poverty, which is all pervasive, it affects every part of your life and your access to health care. The diseases that we see, and even the epidemic diseases, the health resources that so often are not coping. Instability in countries, and other burdens of disease. And of course, we've mentioned this before, but we actually have no model for dealing with the number of displaced persons around the world, and we know this is an urgent and an increasing problem that we need to look at. So when I had a look at the models for children's palliative care, and I really want to acknowledge that there are amazing models out there in the developed and the developing world. Each one has a focus on improving the quality of life of children. But there are a number of issues that really impact on the development of the model. And one was very importantly, the vision of that person who had the idea to start the model. And that sometimes impacted over a long period of time. Secondly was the context. Was this developing because it was part of a national development of children's palliative care, or was this developing in response to a particular problem in that region, as in Africa we saw with HIV? And then, of course, we're looking at very different resource levels. But what is very interesting is to see how models in developing countries have actually taken ideas from the developed world and have changed them. And then, of course, things like the program elements, because every model is built up of different building blocks. And what has this model decided they want to do? And then what really impacted so much was how prepared were they to collaborate and to network? Because while there are some really beautiful models that provide wonderful care, they do survive in really splendid isolation. And the more people collaborate, the more integrated is the model. And so when people were putting these building blocks together, like children do, how many of you have got children? I'm sure there are lots of you. And when they start building, they build a tower and they build a little house and they knock it down. And I think a lot of these programs have been like this. They've started with a vision perhaps of a home care program or an inpatient unit, or it's a hospital-based program. And as it's grown, things have added on to it. But what we've also found when looking at the development of these integrated models, that there was an element of serendipity. Things happen that you hadn't believed were going to happen. Things happen that you were nowhere on your horizon. And it was often the serendipity that changed the focus and allowed this model to expand. What we found also is that in general, they used the WHO definition, or one of the other very good definitions that are out there, which basically contain the same elements. And they added extra, looking at what the children's needs were. So of course, play and development. We're dealing with children from newborns up until young adults. I mean, there's a wide range of developmental needs there. That they were all very focused on protecting children's rights. So child protection was part of what they were doing. That they were integrating not only from a generalized to a specialized service, but they were integrating the private and the public services as well. Education was a really important part of what they were doing. So education of their own staff, but also educating of others. So it was education in and going out. And then, of course, they developed in accordance with their culture. And the services that they provided are very much culturally relevant. And I think when we look at palliative care, it's a very rational response to a need that demands our compassion. And if I look at these programs that are so well integrated, they are very rational in the way they have developed and the way they are run and managed. And so I thought we'd look at just a couple of examples in low and middle income countries and see how they were done, because it's always good to see it in practice, isn't it? And these are programs that saw there was a big challenge and said, but this isn't too big for us. The first project was actually a planned development. It was a development that we did in Malawi and in the Maharashtra region of India. And we took a model program in each region, and we used that as a model and a mentor for the development of 3 more programs. And then we added to that education, because that is basic on development, and advocacy to impact on policy. And what we found is that using a rational approach, it worked. These models eventually changed the policy in Maharashtra, led to funding for children's palliative care, has led to the beginning of a special grant for children with palliative care needs, and has trained from the professions with that policy change. And we have children who are in this continuum of care, because the models include care in the hospital and home-based care as well. And they include primary care in the home and more specialized care through the hospital programs. And this model is now being further expanded into 2 new sites. Then it's very good to have Jane Bates here, because she heads up the Palliative Care Support Trust in Blantyre in Malawi, and the children's part of that began as an NGO within the Department of Pediatrics. So again, this NGO that started linked to the formal healthcare system. From the beginning, it provided care to all the different diagnoses in the hospital. And from the beginning, it also did outreach into the community. And this particular model has now been taken and expanded through Malawi. It's part of a step-up program that is taking children's palliative care into the community. And again, just as the Tata model showed, the one in Maharashtra, is that it is providing levels of care from primary health care up into more specialized health care as well. And then the one that I've been particularly involved with, and when I talk about Serendipity, I think this is a program that has developed through Serendipity. It started with the development of a children's hospice in response to HIV and AIDS, when the children were dying because we didn't have access to antiretrovirals. But the impact has now been that the Department of Family Medicine has taken leadership and is working with the Department of Pediatrics. So while the leadership began with a hospice, it is now well firmly established within a university and a government service. And through the linkage with the hospice, it is providing care in the home, it's getting the community involvement, and it's even reaching into the prisons and has been for the past 14 years. So it developed not according to the original vision, but it has developed into a well-integrated model of care. And so what were the key elements that we see in these programs? Well, first of all, I think that the vision was larger than the program, and we tend to all bite off more than we can chew. That the vision was held even when the leadership changed, but that right from the beginning, these programs didn't see themselves in splendid isolation. They saw themselves as part of a bigger healthcare system. And so from the beginning, they collaborated and they networked. They were all adaptable. If we look at where they are now as to where they were in the beginning, it's a world of difference. And they also have the strong public-private partnership. So equal partnership between the formal health sector and civil society, and a recognition that they need each other. And the only way they can provide this wonderful continuum of care is through this. And they have been sustained over a period of time, which is really important. Sustainability is the biggest challenge. Lack of funding, lack of policies, lots of competing priorities, and the challenge of sometimes poor access to palliative care medicines, but somehow they have survived. And I think the basis of this is because the people who work in these programs are really passionate and compassionate about the children that they care for. And I think if we don't have that passion, if we don't have that compassion to care for these children from their homes into the more specialized care centers, then we're not going to be able to make it work. So thank you very much.